Bismillah. Assalamu alaikum. I'm Dr.Rawan Hamarsheh, and today I would like to present a project that is very close to my heart, your family medicine companion. I want to begin by clarifying the spirit of this work. I have not yet completed residency, and I'm not presenting this book as the final voice of a specialist or as a replacement for textbooks, guidelines, or senior clinical judgment. I'm presenting it as the structured outcome of 2 unusually focused years inside family medicine residency. 2 years of reading, observing, questioning, discussing, comparing sources, solving board-style cases, and trying almost obsessively to understand the real soul of family medicine. This was not a side project built casually. It became a deep intellectual and emotional devotion. There were many days of long uninterrupted desk work, sometimes extending for hours, not simply to collect information, but to chase something more difficult to define: how family physicians truly think, how they sit with uncertainty without rushing, how they see the patient beyond the disease, how they balance science with humanity, how they prevent illness before it appears, and how they remain present across time, not just across visits. I found myself repeatedly asking, what makes family medicine different at its core? It is not only the breadth of knowledge. It is the continuity, the responsibility, the quiet decision making, the ability to hold complexity without fragmentation, and the commitment to the patient as a whole person within a family and a community. Understanding this was not immediate. It required persistence, reflection, and a kind of obsession with getting closer to its essence. So the value of this book does not come from claiming complete expertise. It comes from being built at the exact point where the resident's need is most visible: during training, while facing rotations, exams, clinics, procedures, counseling encounters, and the constant question of how to turn knowledge into a thoughtful, patient-centered practice. When I first entered family medicine residency, I attended the Wonka conference, and I remember being struck by the way people spoke about family medicine. They did not describe it only as a clinical specialty. They described it as a philosophy, a way of seeing, a lens through which the physician understands the patient, the disease, the family, the community, the risk, and the future. At the same time, our family medicine workshops and training, we were being introduced to concepts that were clearly different from pure biomedical knowledge: the patient-centered approach, ICE, counseling frameworks, continuity of care, prevention, safety netting, and consultation closure. And I found myself asking a question again and again: what is the family medicine lens? Not in a vague or poetic way, but in a practical way. How does a family physician look at chest pain differently? How does a family physician approach diabetes differently? How do we think about headache, child with fever, pregnant patient, smoker, patient with vague fatigue, or someone who is not ready to change? I started to realize that family medicine is not simply a smaller version of internal medicine, pediatrics, obstetrics, psychiatry, dermatology, or emergency medicine. It is not a collection of fragments from other specialties. It has its own intellectual identity. Family medicine is the discipline of first contact. It meets disease before it is fully labeled. It manages uncertainty before all the investigations are complete. It follows patients over time. It sees prevention before complications occur. It treats the disease, but it also listens to the person who carries it. This realization changed the way I studied. I stopped asking only what is the diagnosis and started asking, how would a family physician approach this safely, practically, differently, and humanly? From here, I became deeply interested in clinical reasoning. I wanted to understand not only what good physicians know, but how they think. How do they move from a messy patient story to a clear problem representation? How do they recognize danger early? How do they build a differential without drowning in possibilities? How do they choose the one question, one sign, or one test that actually changes the plan? During that journey, I was influenced by the book Symptom to Diagnosis by Scott, Adam, and Diane, especially its disciplined approach to symptom. It helped me see that a symptom is not just a complaint, it is an entry point into structured reasoning. I was also influenced by the Clinical Problem Solvers, a clinical reasoning education team and podcast known for teaching cases through problem representation, diagnostic schemas, illness scripts, and differential diagnosis buckets. Their way of thinking made clinical reasoning feel alive. It was not about memorizing endless lists, it was about organizing uncertainty. Gradually, these ideas started to connect with what we were learning in family medicine: CRAP, pre-op for management closure, ICE for ideas, concerns and expectations, the 5 A's for counseling, stages of change, motivational interviewing, spikes for breaking bad news, safety netting, documentation, and follow-up. And this is where the real idea of the book began. I wanted to bring diagnostic reasoning and family medicine consultation skills into one practical framework. Because in real family medicine, diagnosis is only part of the consultation. A good family physician must think, speak, examine, manage, counsel, document, prevent, refer, reassure, and follow up. The consultation is not complete when we name the disease. It is complete when the patient understands the plan, knows what to watch for, and has a safe next step. So I tried to build a structure that reflects this full process. At the same time, I was watching the reality of residency around me. Residents are expected to move through many rotations, prepare for oral exams and OSCEs, manage emergencies, learn procedures, counsel patients, follow guidelines, and understand the Jordanian family medicine residency curriculum. But the resources are scattered. One source teaches counseling, another teaches procedures, another teaches emergency scores, another teaches clinical reasoning, another teaches communication, another explains the curriculum. All of them are useful, but the resident can still feel lost. So the question became more practical. Can we build one companion that gathers these scattered needs into a clear structure? Not a textbook to replace references, not a guideline to replace official protocols, but a companion that helps the resident know how to approach, how to speak, how to perform, and how to grow. That became your family medicine companion. This book is built around 8 sections. And each one represents a different layer of training. The first section is the framework part. This is the foundation of the book. It contains the 5-layer approach, CRAP pre-op, ICE, the 5 A's, stages of change, Safer X, and the 4-minute drill. This part answers the most important question: what is the structure underneath a confident consultation? It teaches the resident to start with safety, define the problem, organize the differential, choose discriminators, and close with a plan and follow up. In other words, it trains the thinking before it trains the topic. The second section is the clinical station part. The book includes 60 clinical encounters across the major domains of family medicine. These are designed not only to be read, but to be practiced aloud. Each station moves from the stem to the opening line, the framework, the important numbers, red flags, examiner traps, guideline anchors, the 5-layer approach, SOAP note thinking, model spoken answer, and practice variants. This is where knowledge becomes performance. The resident is not only asked to know diabetes, chest pain, asthma, anemia, headache, or abnormal uterine bleeding. The resident is trained to present them clearly, safely, and confidently. The third section is the emergency part. This part focuses on time-critical presentations such as stroke and transient ischemic attack, acute chest pain, pulmonary embolism, appendicitis, abdominal aortic aneurysm, severe asthma, sepsis, anaphylaxis, and upper GI bleeding. The purpose here is to train the first few minutes of thinking. In an emergency, the best answer is not the longest differential. The best answer begins with stability, danger, immediate action, escalation, and reassessment. This section teaches the resident to think in parallel, stabilize while diagnosing, treat while investigating, and refer while monitoring. The fourth section is the risk stratification part. Emergency scores and guidelines are included because real decisions often require more than impression. Tools like HEART, WILS, PERC, Geneva, ABCD2, CT rules, pneumonia scores, appendicitis scores, GI bleeding scores, and pediatric emergency scores help convert uncertainty into safer decisions. They do not replace clinical judgment, but they make judgment more disciplined. They help answer the practical questions that matter. Who can go home? Who needs admission? Who needs imaging? Who needs urgent referral? And who should never be falsely reassured? The fifth section is the procedural part. This section covers the skills such as suturing, IUD insertion, implanon insertion and removal, pap smear technique, neurological examination, Epley maneuver, joint aspiration and injection, lumbar puncture, local anesthesia, incision and drainage, and slit lamp examination with foreign body removal. The idea is that a procedure is not merely a hand movement, it is a clinical decision. So a safe physician knows the indication, contraindication, consent, equipment, steps, complications, aftercare, documentation, and follow-up. This section supports OSCE skills, but also reminds us that technical competence must be surrounded by judgment. The sixth section is the counseling part. This is one of the parts that most clearly reflects the soul of family medicine. Many consultations are not solved by prescriptions alone. A newly diagnosed diabetic patient needs education and follow-up. A hypertensive patient needs risk explanation and adherence support. A smoker may need motivation before medication. A woman asking about contraception needs safety, eligibility, preference, and shared decision-making. A vaccine-hesitant patient needs respect before advice. This section uses the 5 A's, ICE, stages of change, motivational interviewing, and practical scripts to show the communication that communication is not decoration. Communication is part of the treatment. The seventh section is the symptom approach part. I named it extra detailed approaches. The deeper the approach, the clearer the decision. This part addresses common and difficult presentations such as chest pain, headache, cough and shortness of breath, arthritis, and chronic fatigue, hematuria, proteinuria, enuresis, obesity, hyperlipidemia patterns, risk stratification, and medication decisions. This section is important because patients do not usually arrive with chapter titles. They arrive with symptoms, fears, abnormal labs, vague complaints, and uncertainty. The family physician must begin with the presentation, protect against danger, organize possibilities, and decide what is common, what is serious, what is urgent, and what can be followed safely. The eighth section is the residency map part. This section turns rotations into competencies. It asks, what should I read before this rotation? What presentations should I master? What procedures should I log? What questions should I be able to answer? What matters for family medicine practice and board preparation? It is designed to reduce the feeling of being lost and to help residents move through training with purpose. It is the curriculum translated into a checklist. So when I look At the book as a whole, I do not see 8 separate sections. I see one educational journey. The frameworks teach how to think, the stations teach how to speak, the emergency cases teach how to act under pressure, the scores teach how to stratify risk, the skills teach how to perform safely, the counseling section teaches how to reach the patient, the detailed approaches teach how to manage uncertainty, and the residency guide teaches how to grow deliberately through training. This is why I called it a companion, because the goal is to accompany the resident while building the mind of a family physician. A mind that is structured without becoming rigid, broad without becoming scattered, safe without becoming fearful, patient centered without losing clinical precision, confident enough to act, and humble enough to follow up. I also want to be transparent about the role of AI tools. AI was used in this project as an assistant for organization, formatting, rewriting, comparison tables, and large amounts of material, but it was not the source of the idea, the clinical lens, or the educational purpose. The journey came from residency, the questions came from practice, the frameworks came from learning, mentorship, and clinical reasoning resources. The responsibility for selection, correction, verification, and direction remained human. AI helped translate the idea into a clearer product. It did not create the journey behind it. The book is not perfect, not final, and must always remain open to review, correction, and updating. Your Family Medicine Companion is not just a document, it is a map of how I learned to see family medicine. It began with one question: what does this mean from a family medicine perspective? And after 2 years, the question became a project that tries to help residents study with less confusion, approach patients with more structure, and grow into family physicians who think clearly, communicate wisely, practice safely, and adapt the true spirit of family medicine. That's why I'm presenting your Family Medicine Companion today. And you will find in the book an appendix for each rotation with further guidance for topics that must be covered and studied, for protocols, for procedures, disease cards, and many interesting stuff. Thank you.